I watched the patient vomit blood and I froze. Not a little blood. I'm talking about dark coffee ground looking blood filling an entire MSS basin. The smell was overwhelming. The patient was pale, sweating, heart rate was 130. And I just stood there. I knew something was wrong. I knew this was bad, but my brain couldn't process what to do first. Do I call the doctor? Do I start IV fluids? Do I get the blood pressure? Do I lay him flat or sit him up? It felt like 5 minutes, but it was probably 10 seconds. And then my nurse preceptor walked in, took one look, and went into action. Large bore IVs, 2 liters of fluids, type and cross for 4 units of blood, called GI now. For GI consult, that was one day I learned upper GI bleeding isn't just a diagnosis, it's an emergency. And if you don't understand what is happening inside the patient body, you're going to stand there and watch them die, literally. So today I'm going to teach you everything I learned that day and everything I wish I had known before I walked into that room. So we're going to be talking about upper GI bleeding and why it happens, acute pancreatitis and why it hurts so bad, liver failure and the complications that cue. This is about 50 minutes. So grab your coffee, your notes, and let's talk about GI emergencies. You're going to know exactly what to do. And the next time you see coffee ground MSs, you're not going to freeze like I did. You're going to know exactly what to do. So let's go. They do say you learn better from experience, but hope it doesn't happen to you. Okay, real talk. Why do GI emergencies scare nursing students? Number one, they are messy, blood, vomit, black varices. It's not pretty. Number two, they happen fast. A patient can be stable 1 minute and in a hemorrhagic shock the next. Number three, the anatomy is confusing. We got the esophagus, stomach, duodenum, pancreas, liver, gallbladder, and they are all connected in ways that make diagnosing problems complicated. That's the word. But here's the thing, GI emergencies follow a pattern. Once you understand the patterns, everything clicks. So, upper GI bleeding, it's almost is if it's upper GI bleeding, it's always one of these four things: peptic ulcer, stress ulcer, esophageal varices, Mallory-Weiss tears, Mallory-Weiss, no, not Walls, Mallory-Weiss tears. Acute pancreatitis is usually alcohol or gallstones. Liver failure, cirrhosis, hepatitis, or toxins. So today, I'm breaking down each one, not just what they are, but why they happen, what you should expect to see in your patient, and what you need to do ASAP. Because here's what nursing school doesn't tell you. These conditions don't just make the patient uncomfortable, they kill. Upper GI bleeding can lead to hypovolemic shock. Pancreatitis can lead to ADS and multi-organ failure, otherwise known as septic shock. Uh, Liver failure can lead to encephalopathy, coma, and death. So yeah, this matters. This is life or death nursing. Ready? Let's start with the one that scared me, Apache bleeding. So, all right, Apache bleeding. Let me explain. Let me explain what is actually happening. So, upper GI, that is everything from your mouth down to the first part of your small intestine. So, what are we talking about? We're talking about esophagus, we're talking about stomach, we're talking about duodenum. Why any of these areas start bleeding, blood comes up. Hemat- hematem- hematemesis, blood vomits, or goes down. So it's either it's coming up or it's going down, and it comes out as black tarry stew, also known as melena. And yes, melena smells awful. You know it when you smell it. It's like literally unforgettable. It's like, yeah, I had the experience. Yeah, I'm not going to talk about that, but yeah. Now, here's the critical part. Your biggest concern is not the bleeding itself. Well, it's somewhat important, but your biggest concern when you see that is hypovolemic shock. When a patient loses blood fast, their body can compensate. Or their body start compensating, but there's only so much their body can compensate. Their blood pressure initially goes up, then it drops. Heart rate goes up, organs don't get enough oxygen, and if they don't catch, and if we as nurses don't catch the symptoms early, that's when we're having those patients that are coding on us, code blue. So let me tell you what to look for. Early signs of blood loss: heart rate of over 100, that's your tachycardia, otherwise known as tachy. Patient says they feel dizzy or lightheaded, they're restless, skin feels cool, clammy, urine output starts dropping. That's your cardiac system, that's the heart rate goes high. Patient says they're feeling dizzy or lightheaded, that's your nervous system hitting you up. Hola, something is wrong, do something. Skin is your another next one. Then your kidney. Your kidney are like, okay, the heart's not giving me enough blood, so I'm gonna, try to save myself. Late signs of blood loss: blood pressure dropping. That's your systolic is over 100. So if maybe let's say this patient is hypertensive and all of a sudden their blood pressure dropped from 150 over 90 to 90 over 65. Ding ding ding, that's problem. Heart rate is really fast. The heart rate is the tachy again, over 120. The patient is confused or lethargic, weak, drowsy, sleepy, and there's no urine outputs. Maybe within 2 hours, there's nothing urine outputs. If you're seeing late signs, you're already behind. You should have caught it in that early signs when they were still compensated, because there's the initial stage of shock. That one you don't really know. But when they're in the compensatory stage, you need to be catching those things, because when they enter the late signs, that's they're already declining seriously, having organ failure. You don't want them to get there. So if you're seeing late signs, you're already behind. This patient is heading towards shock and they need aggressive intervention now, ASAP. Okay, so let's talk about the causes, because where the bleeding is coming from changes from how where the bleeding comes from changes how you treat it. Does that make sense? It should be making sense. Okay, one, peptic ulcer disease. This is upper GI bleeding segment we're talking about. This is an ulcer. Basically, it's an open sore in the stomach or duodenum. Peptic ulcer disease. Why does this happen? The H. pylori bacteria, not the fun one, it eats away at the stomach lining. That's it. It's like the stomach lining and then it's eating it. NSAIDs like ibuprofen, they block protective prostaglandin. I hope I did justice to that pronunciation. Smoking increases stomach acid. Stress, when you're stressed, your body feels it and it affects your body. So they also arose through the mucosa and it's a blood vessel. Boom, bleeding. So basically, whatever is the cause of this disease, if it's H. pylori bacteria, if it's NSAIDs, if it's smoking, if it's stress, it basically makes a hole, and then the deeper it gets, and boom, it's a vessel in the stomach or the duodenum, and then you have bleeding. Patients with peptic ulcer usually have a history of stomach pain, especially after eating or at night. Or no, two. No, sorry. Number two. It's a work on my Spanish. Stress also. We talked about stress being one of the causes for peptic ulcer. So stress also, it happens in ICU patients who are really sick. So we're talking about those patients with trauma, burns, sepsis, head injury, any major psychological stress. Why? Because decreased blood flow to the stomach lining, the tissue gets ischemic, necrosis, breaks down. So basically, when they're really sick, their body goes to the blood flow focuses to the major organs for survival. Do you know the five major organs for survival? That's the brain, the heart, the lungs, the kidney. The fifth one is not coming to me, but yeah. Anyways, the stomach is not in that. Is not the stomach. The digestive system is not in one of the major five organs. If I remember the fifth one, I'll let you guys know. But it's just escaped me at this moment. Does this happen to you guys? Anyway, back to topic before I digress. Basically, the blood flow leaves the stomach lining and focuses on those major systems, major organs. And so when that happens, the stomach lining, the tissue in the stomach lining gets ischemic up and then breaks down. This is why we give stress ulcer prophylaxis in the ICU. What do you think? What do you think? Why do you think every ICU patient, except if they're allergic, of course, get PPIs, that's your proton pump inhibitors or H2 blockers? It's part of the ICU bundle because prevention is way easier than treating a bleed. Number three, esoph- esoph- esophageal varices. This is a very scary one. Even with the name and the difficult to pronounce it, you know it's one of the scary ones. Varices are enlarged. They are enlarged, fragile veins in the esophagus that develop because of portal hypertension. Okay, let's get into this. Portal hypertension means the blood pressure in the portal vein. Portal vein is the vein going to the liver. So it's too high, too much blood pumping. No, okay, let's start again. Portal hypertension means the blood pressure in the portal vein, that is the vein going to the liver, is too high. It's usually because of cirrhosis, that's the scarring of the liver from chronic alcohol or hepatitis. The blood can flow through the liver properly, so it backs up and finds alternate routes. This alternate route, veins in the esophagus. Get it? These veins in the esophagus, they're not meant to handle high pressure, so they balloon out. When they balloon out, you know when you blow so much air in a balloon, it becomes fragile, and if you keep blowing, ruptures. That's what happens. When viruses bleed, they bleed fast. Patients can lose massive amount of blood in minutes. This is a cold situation. And finally, Mallory-Weiss tear. Mallory-Weiss tear. It is a tear in the esophagus from forceful vomiting or retching. This is what we're worried about in those people that have eating disorder, the bulimic, anorexia, when they keep vomiting the acid in our tummy is very strong. For it to come out through our esophagus is not meant to take acid. So when it keeps having that, that's why you have your Mallory-Weiss tear from forceful vomiting or retching. So think alcoholic who has been vomiting all night or patients with severe nausea from chemotherapy. The forceful pressure literally tears the tissue. It bleeds, but usually not as severely as varices. So varices is the worst one on the list. So now you know the focuses. Let me tell you what you actually see when you walk into that room. So you walk into your patient's room. What are you looking? First, look at your patients. Remember, I always say this. Look at your patient first, not the monitor. You can look at the monitor after you've looked at the patient. Now, when you look at your patient, are they pale? That's a sign of blood loss. Are they sweating? That's a sign of shock. Are they restless or anxious? Their brain is not getting enough oxygen. Are they confused? That's a late sign. They are severely, no, that's a late sign. They're severely hypovolemic. Now, you need to check their vitals immediately. Heart rate, is it over 100? Is it over 120? That's tachycardia compensation for blood loss. Blood pressure, is it normal? Is it dropping? Remember, blood pressure might be normal at first because the body is compensating, but once it drops, once the heart stop pushing, stop fighting, stop compensating, you're in trouble. A systolic BP under 100 or a drop of more than 10 mmHg when they sit up, that is orthostatic hypotension. That means they have lost at least 1000 ml of blood. This is about 25% of their total blood volume. Not good, not good. Now you also need to check urine output. Normal for adults is at least 0.5 ml per kilogram per hour. If they are not peeing, their kidneys are not perfusing. That is a ding 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 red flag. Fourth, look at what they're vomiting or what is coming out of the under end. Vomit or their poop. What does it look like? Hematemesis is vomiting bright red blood. This is arterial bleeding. It is active and it's emergent. And then we have coffee ground emesis. That's when they're vomiting dark, grainy looking blood. The blood has been sitting in the stomach for some minutes and then it has mixed with gastric acid. It is still serious but not as active as the hematemesis when they're breathing bright red blood. Melania, that's the black terry stool, very foul smelling. It indicates upper GI sauce. It says the blood has been digested as it passed through the GI tract. And then there's hematochisa. That's when they have bright red or maroon stool. Maroon is that dark red burgundy color. And it usually means the lower GI if it's happening fast from an upper source. Blood doesn't have time to turn black. Here is a clinical pill. If your patient has both hemostasis when they're breathing, that's vomiting bright red blood, and they have melania, oh my goodness, that is double trouble. They're vomiting bright red blood and they're also pooping it out. They are losing a lot of blood. This is not a small bleed. This is a huge one. Now, also want to check the abdomen. Listen to you know how you have right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. That's how you check for the vital sounds, the U, N shape or U shape. Basically, you check the abdomen, you listen for the bowel sounds in that order, like that, and you see if they're hyperactive, non-active. Basically, if they're hyperactive, it means their gut is irritated by all that blood. Palpate gently, like this. Just palpate gently. If they're tender, are they tender? So when you're palpating, what you're checking for is, are they tender? Are they rigid? Are they guarding like this, like when they move away and they try to protect themselves from you touching them? If you feel a rigid blood-like abdomen with severe tenderness, that is peritonitis. That ulcer might have perforated, and that is a surgical emergency. Okay, so now you've assessed them, you know your patient is bleeding. What do you do? All right, intervention. What do you actually do? All right, your patient is actively bleeding. Here's your action plan. Step 1, call for help. Don't try to manage this alone. Call rapid response team, call the attending doctor, call GI consults, get people in that room, people that can help you. That's why we have interdisciplinary team. Step 2, ABCs. Airway, breathing, circulation. Airway. Is it patient? Are they protecting it or are they aspirating blood? Breathing. What is their respiratory rate? Oxygen saturating. Start supplemental oxygen if needed. Circulation. This is your priority because they're losing blood. Step 3, get IV access. Big IVs. This is why they like to, when any patient come into the ER, they start them with, I think, 28 engage because those are the big ones. You can easily put a lot of stuff in there. Anyways, you need at least 2 large bore IVs. That's your 18 gauge if possible. You're going to be running fluids and blood products very fast. Step 4, you need fluid Resuscitation starts with crystalloids, normal saline or lactated ringers, wide open initially. We're trying to maintain blood pressure and organ perfusion. But here's the thing, fluids are just a bridge. They buy you time. You do it to buy you time, but you're getting the other stuff ready. What this patient really needs is blood. And the processing of blood takes a minute because you have to match, you have to do all of those things, make sure they have the donor, blah blah blah. Those good process. So the IV fluids is buying you time. Step 5, type and cross for blood products. Order at least 2 to 4 units. That's the doctor doing that part, but 2 to 4 units of packed red blood cells. And if they're really unstable, you might need more blood, but at least just get them started. 1 unit of packed red blood cells increases hemoglobin from about 1 g/dl and hematocrit by 2 to 3%. That's just 1 unit of packed red blood cells. 1 unit of packed red blood cells has 325 ml in it. So you're going to watch for transfusion reactions, fever. What are the blood transfusion reactions? That means when I say that, it means their body does not like that blood. They do not agree with that blood you've just given them. So the signs or symptoms you should be seeing are fever, chills, hives, back pain, and also monitor their potassium and calcium because blood products can cause electrolyte imbalance. Now, you're going to insert NG tube for gastric lavage. This is where you insert a nasogastric tube and flush the stomach with room temperature saline to clear out blood and clots. Remember this, yeah, to clear out blood and clots. Why? So the GI team can actually see where the bleeding is coming from during endoscopy. You use 1,000 to 2,000 ml of normal saline. Gently flush in, then suction out. Repeat until the return is clear or light pink. Don't do this if you suspect varices. Varices, remember, are fragile. The NG tube could make esophageal varices bleeding worse. Wait for the GI team guidance. Basically, all of this is not us guys doing it, but know what to expect, know what to do. When the patient comes for GI bleed, they are NPO automatically. They are nothing by mouth, except if they have PO meds, but basically nothing by mouth. Step 7, medications. That's where our PPIs come in. Proton pump inhibitors like pantoprazole. It reduces the stomach acid production. And if it's varices, osteoarthritis drip, it basically reduces blood flow to the GI tract and then lowers the portal pressure. If it is an H. pylori bacteria, bacteria also that's under the peptic also, antibiotics after they're stabilized. Now you need to also prepare for endoscopy. This is both diagnostic and therapeutic. The GI team will scope the patient, find the bleeding source, and try to stop it. They might use, I was able to do one of my rotation at the GI, so they might use terminal coagulation to eat to seal the vessel. Injection therapy, epinephrine or sclerosing agents. That's the injection therapy. Band ligation, that's for varices. So tie them off with rubber band. Our job is to keep the patient NPO, nothing by mouth. Monitor vitals closely and make sure they're stable enough for the scope. Now, step 9, you want to monitor for complication. You want to watch for continued bleeding, vitals is deteriorating, more bleeding, more blood. Aspiration, the blood is going to the lungs. Oh my goodness, you never wanted to get that far. Perforation, rigid abdomen, severe pain, shock. Shock is hypotension, altered mental status. If all of this fails, they're still bleeding, Despite endoscopic intervention, then we need to enter invasive treatment, and that's surgery. They might need a gastric resection. Oh God. Vagotomy, or if it is varices, they need TIPS procedure or surgical shunts. Okay, but hopefully, you caught it early, you intervene fast, and bleeding has stopped. Amen. We never wish to pray for complications. Now let's talk about something just as painful but in a different acute pancreatitis. The pain that makes patients scream. If you've never seen a patient with acute pancreatitis, let me tell you, it's pain like you've never seen. This patient are rating, can't get comfortable. They look there, they're in fetal position, they're vomiting, they're sweating, they look absolutely miserable. And when you ask them on a scale of 1 to 10, how is your pain? They're going to be telling you 15 out of 10, 20 out of 10. Yes, that is how bad it is. So you say, what is pancreatitis? Well, the pancreas is an organ behind your stomach. It does two main things. It makes digestive enzymes, exocrine function, and then it makes insulin and glucagon, endocrine function. Yeah, anatomy and physiology, yes. In pancreatitis, the digestive enzymes get activated inside the pancreas instead of the intestine where they're supposed to be. So when they leave so your pancreas makes the digestive enzyme, but it's not activated. It's unactivated until it gets to where it's meant to be, then it's activated. But when they have pancreatitis, their digestion starts from the pancreas. Autodigestion. No, not good. So the pancreas literally start digesting itself. That is the digestion I just spoke about. The enzymes eat away at the pancreas tissue and the pancreatic tissue. They cause inflammation, swelling, bleeding, and in severe case scenarios, necrosis, dead tissue. Now, mild pancreatitis is uncomfortable, but it's manageable. You see that severe pancreatitis, that is life threatening. It could lead to shock, heart, multi organ failure, and death. Yes, death. So, what causes this? Number one cause, alcohol. You see, when they preach to you, when your nurse tell you, please, can you stop drinking? Stop drinking. This is it. Alcohol is not good for you. It does a lot of things to your body. But anyway, chronic heavy drinking damages pancreas over time. Then one day it just tips over the edge. Boom, into acute inflammation. So someone could have been drinking for 20 years, they are okay, they don't have no problem, maybe they have a big tummy. But you see, it damages the pancreas, the consistency, the compounding. And then one day the pancreas gives up on you and it just goes into acute inflammation. Number two cause, gallstone. A gallstone gets stuck in the bile duct. It blocks the pancreatic duct. So the enzymes backs up into the pancreas. Boom, pancreatitis. And then there are other causes like certain medication like steroids, antibiotics, trauma like car accidents, abdominal injury, high triglyceride level. That's why you need to watch your cholesterol. And sometimes we don't know the cause because it's idiopathic. That's when you don't know the cause, basically. Now, let me tell you what the pain looks like. It is epigastric or mid abdomen, right in the center or slightly to the left. It is constant. Like the patients will describe it as it radiates to the back. Patients will say it feels like someone is stabbing me through my back. It is constant. It doesn't come and go. It's just unrelenting. And nothing else. Not position change, not medication. At first, medication helps, then nothing. They are also nauseous and vomiting. They can't keep any food they eat down. The abdomen is distended and tender, sometimes jaundiced. Yellow skin and eyes if bile duct is involved. Remember, bile duct is the liver. And if it is severe, you might see calling sign blush discoloration around umbilicus, tunnel sign blush discoloration on flanks. Let's see your flanks. Okay. This signs means hemorrhagic pancreatitis. Blood is leaking into the retroperitoneal space. This patient is in bad shape. Now, how do we diagnose it? Lab work. We need to analyze elevated. We need to analyze their labs that are elevated. So they return to normal in 3 to 5 days. Lapis is elevated. It stays up longer. That's 8 to 14 days. Lapis is more specific for pancreatitis. Calcium drops. That indicates fat necrosis. That's not good. That's a bad sign. Remember, your calcium is 8 to 10. Yes, around that range. But it drops. That's not good. Glucose is elevated, or your pancreas is involved. So yes, your glucose will be elevated. White blood cells is elevated. Your body is trying to protect itself, so it's gonna spike. Now your imaging. What you should see on the imaging, the CT scan of abdomen, it shows inflammation, swelling, necrosis. Ultrasounds looks for gallstones. There's a scoring system called Ransom criteria. Basically, the more criteria a patient meets, the higher their risk of dying. That's not good. Less than three criteria is 1% mortality. Seven or more criteria, nearly 100% mortality. Yeah. So how do we treat it? We rest the pancreas. How do we rest the pancreas? You say the pancreas makes enzyme in response to eating. So if we stop the patient from eating, we reduce enzyme production. Patient are NPO, nothing by mouth. We place an NG tube to decompress the stomach, suction out gastric contents so they don't stimulate the pancreas. We shift to fluids. We give massive amount of eye refills because they need to be hydrated. Why? Because pancreatitis causes third space fluid. Because pancreatitis causes third spacing fluid leaks out of blood vessels into the tissue and abdominal cavity. Patients can become severely hypovolemic. Lactated fingers is preferred, sometimes colloids or even blood products. We monitor them closely, central line, sometimes even a PA catheter, swangers, to monitor fluid status. We're aiming for a pulmonary artery wedge pressure of 11 to 14 mmHg. Normal of a pulmonary artery wedge pressure is 8 to 12 mmHg. So we're aiming for 11 to 14 for these patients. It's just for them. Now, here's where it gets controversial. Nutrition. Old thinking is keep them MPO for days. Give perinatal nutrition. That's the TPN through IV. New evidence state early enteral nutrition through a feeding tube into the jejunium is better. It reduces infection, promotes healing. The key is feeding past the stomach. Remember, the pancreas is behind the stomach. So you want to feed past the stomach and the duodenum down into the jejunium. Remember the way the system goes. So you don't stimulate the pancreatic secretion. And pain management, yeah, they're going to be in pain. So we need to treat that. This patient needs not NSAIDs. No, that's not good for them. They need, well, not at this moment, they need opioids. Strong ones. We're talking fentanyl, we're talking hydromorphine, we're talking morphine. Sometimes PCA pumps. There used to be concern that morphine causes spasm of the sphincter of the Odi. Odi is the opening where the pancreatic enzymes enter the intestine. But current evidence says it's fine. Pain control is more important. Now, like with everything, there's always complications to watch for. So what are we watching for? Shock from fluid loss, adds respiratory failure, uh, pedo, pistol, cyst, that's fluid-filled sacs that can rupture or get infected, abscess, DIC, that's disseminated intravascular coagulation, renal failure, death. Pancreatitis is no joke. These patients are critically ill and they need close monitoring. Now, last topic, and this one is complex. Hepatic failure. Liver failure, this is where things get complicated. The liver does over 400 different functions. It's basically the body chemical factory. I don't know why it's not part of the five major organs, but it should be. Because we don't even think of the liver. But the liver is doing some things. 400, it's responsible for 400. Okay, let's go to the main thing. So what does it do? As a body chemical factory, it filters blood, it makes clotting factors, it metabolizes fat, carbs, and protein. Yes, that's what is metabolizing it. It stores your vitamins, all those good vitamins you're taking. The liver is in charge of that. It produces bile for digestion. It detoxifies drugs, alcohol, and ammonia. Lord, do I need to go on? So when the liver fails, everything falls apart. What causes liver failure, you say? Hepatitis. That's why we have to take the vaccine for it. But I digress. Hepatitis is a viral infection. We have hepatitis A to E. So we have hepatitis A, we have hepatitis B, we have hepatitis C, hepatitis D, hepatitis E. Lord. Cirrhosis is the chronic scarring from alcohol or disease. Fatty liver disease is from obesity, diabetes. Then we have acute liver injury from toxins like NSAIDs, acetaminophen overdose, Tylenol overdose. Long story short, let's talk about cirrhosis because that's what you see most in the ICU. In cirrhosis, healthy liver tissue is replaced by scar tissue. The liver becomes hard, shrunken, and bumpy like a hot ball. Scar tissue obstructs blood flow through the liver. Blood that's supposed to flow from the GI tract to the liver through the portal vein can get through. It backs up. So pressure builds up in the portal vein. Now remember that portal hypertension I was explaining? This is it. Portal hypertension. That is where all the complications come from. Now, complication one, we spoke about this, esophageal varices. We already talked about this, portal hypertension, because the blood backs up, and then when it backs up, it finds alternate routes through esophageal veins. Then varices form and rupture. Now, complication two is ascites. Ascites is fluid built up in the abdominal cavity. Why does this happen? That means you have low albumin. The liver isn't making enough protein, so the portal hypertension, that's the fluid, leaks out of the blood vessels into the belly. Good. Plus, the kidneys are retaining sodium and water because of the increased aldosterone. So, what do you see? Patients have huge distended abdomen. They look like they're pregnant, like 9 months type of pregnant, not those 1 month, 2 month, 9 months. The skin is tight and shiny. The fluid shifts. The fluid shifts when they move. So how can we treat this patient? Basically, we're going to restrict their sodium and fluids. Remember, where salt goes, water follows. Diuretics, that's where we have your furosemide, Lasix, and your spironolactone. Lord, yeah, your diuretics. And then we have parasympathetics. That's where they stick a needle in and drain the fluid. It can remove liters at a time. Now, shunting. For severe refractory I just mentioned this. Ascites, peritonevian, peritonevenous shunt. I think I cut it this time. That's the diver or living shunt. It's a tube that drains aside fluid from the abdomen into the venous system. Complication three is hepatic encephalopathy. Hepatic encephalopathy. This is when the patient becomes confused because their liver can't detoxify ammonia. Now, ammonia is a waste product from protein breakdown in the gut. Normally, the liver converts it to urea, which is excreted through by the kidneys. But if the liver is failing, so let me explain again. Ammonia is a waste product from protein. It's protein breakdown in the guts. Normally, the liver converts it to urea, which is then excreted by the kidney to the bladder. You know how that system works. And then you pee it out. But if the liver is failing, it can convert ammonia to urea. So ammonia builds up in the blood. It crosses into the brain. It causes that blood-brain barrier and causes toxicity early. That's when we need to catch it. It's the subtle confusion, like your patient has ill times four is suddenly ill times three. Mild personality changes. They're now more forgetful. Middle stage is this is I can pronounce this word. Asteresis, Asteresis. This is the flipping, no, not flipping, flapping tremor. Ask the patient to hold their arms out and flex their wrist, and the hand will flip like they can't control it. They can't control it. Last stage is when they have severe confusion, very weak lethargy, stupor, coma. Yes, coma. If your patient is in a hepatic coma, they are in end stage liver failure. Prognosis is poor. The only thing that can save them is a liver transplant. Now, treatment for encephalopathy, lactulose, that's when the it makes the gut acidic, so ammonia is trapped in the intestine and is popped out instead of absorbed. So it comes out as poop. So basically, that medication, it makes the gut acid. The gut is your intestine, makes it acidic. So the ammonia is trapped in the intestine and pooped out instead of absorbed. Rifampicin, rifaximin, or neomycin, antibiotics that reduces gut bacteria producing ammonia with excuse me, sorry. Low protein diets. So I know the trend right now is everybody's on protein diet. So basically less protein equals to less ammonia production. Complication four. Oh my god, I'm getting tired. Coagulopathy. The liver makes clotting factors. When it fails, the patient can't clot properly. You would see elevated PT-INR, bruising, bleeding from IV sites, gum, GI tract, risk of hemorrhage. The treatment for this patient will be FFP, frozen, no, fresh frozen plasma, vitamin K, platelets if needed. And our last complication five, is hepatorenal syndrome. That is the liver and kidney. Is in the name. Anyway, this is when the liver failure leads to kidney failure. Now, one organ can work, it affects the next organ. Before you know, we're having multi-organ failure in our hands. Anyway, the kidneys shut down, even though there is no structural damage to them. It is a functional problem related to poor blood flow. You see, when I tell you that if there's low blood flow, the kidneys are the kidneys. They love to swim in blood. They love blood. They like to swim in it. The minute they're not getting enough of it, they do not hesitate to file their complaints. They're going to let you know. So when liver is not working, and then it has not been working for long, it leads to kidney failure. So hypertorenal syndrome has a very poor prognosis. When you're having two organ failure, of course it's going to have poor prognosis. Most patients die unless they get a liver transplant. Hopefully by then, not all of the kidney has failed. So that liver failure, varices, ascites, encephalopathy, coagulopathy, renal failure, a cascade of complication. So let's protect our liver and keep it from getting into all of this situation. By first, if you're an alcoholic, stop drinking alcohol. It comes back to bite your ass. Anyways, your job as the nurse is to monitor closely what's for changes in mental status, prevent bleeding, manage ascites, educate about diets, lifestyle changes, and medication, and provide emotional support because these patients and families are facing a terminal diagnosis unless a transplant is possible. And I don't know if you guys have seen the statistics of transplant, organ transplant, and people waiting, and all of this good stuff. Anyways, let's wrap this up with key takeaways. Let's recap everything you need to remember. Number one, upper GI bleeding is an emergency. Watch for signs of shock, tachycardia, hypotension, urine output. Get large bore IVs, preferable 2, 18 gauge if you can get it in 20 gauge, manageable. Start fluids, type and cross for blood, and call for help. Get as many help as you can into that room. Know your causes for peptic ulcer, stress ulcer, esophageal varices, Mallory-Weiss. Number two, acute pancreatitis is painful. Pain radiates to the back. Patient can get comfortable. The treatment is to rest the pancreas, basically nothing by mouth. Fluids, pain control, the strong one, the good one, opioids, morphine, fentanyl, hydromorphine, Deladine is hydromorphine. Okay. Watch for complications, shock, ads. I keep saying ads. I believe I've thought about this, but ads is acute respiratory disease. Acute respiratory disease. Pestodosites. Number three, liver failure causes multiple complications like portal hypertension causes varices, then ascites. Elevated ammonia causes encephalopathy. Clotting factor deficiency leads to bleeding. Kidney failure causes hypotorenal syndrome. Treatment is supportive. Many patients would need transplant if it's a liver failure. And here's the most important thing. These conditions don't just make the patient uncomfortable, they kill. Your job is to recognize them early, intervene fast, and prevent complications. And yeah, it is overwhelming at first, but you're going to see this patient, you're going to take care of them, and you're going to save lives because you understand what is happening. If this video helped you, hit that subscribe button. We are doing deep dive every week. Next time, we'll be talking about nutritional therapy in critical care, how to feed sick patients the right way. Drop your questions in the comments. What scares you the most about GI emergencies? And what do you think I should cover next? Hopefully, it's something I've learned about. And I know critical care is hard and I know it's very scary, but you're going to be amazing because you are here, you are learning, and you are preparing. And that is what future great nurses do. I would see you next time. Now go study and be the nurse your patients needs and deserve. Till then, kudos. I mean, au revoir, adios, arrivederci. Okay, yeah, bye.